Hello and good evening, students. I am Dr. Ruchi Raj, your original guru for prosthodontics, and I welcome all of you for the rapid rewind session discussing various very important PYQs from the subject of prostho. As always, we'll wait for a few minutes till all of the different students from attending classes or maybe someone's reading here and there, all of you join in, be comfortable, and we can start in the next 2 to 3 minutes. As I can see here, we are live on YouTube. There's a chat box here in YouTube over which you can put in your queries. I'll be helpful to solve them out for you. In the next 45 to 50 minutes or maximum 1 hour, we'll be discussing a range of different previous year questions specifically important for NEET. Towards the end of the session also, I'll target some of the most asked queries that students have put forward in the past 2 months, and let us try and answer those queries as well, and we hope to have a very fruitful session for us in the next 1 hour. So, Rapid rewind is essentially rewinding and learning some PYQs from the past 5 to 7 years of Prosto, specifically targeting NEET. It has a bunch of questions just to diversify and discuss different topics. As always, several other sessions of ours are there even freely available on YouTube, or otherwise, if you are a student and a member, you would have seen all those sessions where we have discussed different topics and almost covered everything that is important in Prostho for the upcoming NEET MDS exam. Now, the mode of the session would be such: I'll take up a question, we can discuss things around it. If there's any query, you can put it in the live chat that is publicly visible. Yes, I can see a lot of students have joined in. Good evening, all of you. And in the live chat, you can just put in whatever queries are there and then we can take them up in details, right? So let us begin with the first question now here from implants. And here it is asking, what is the part that is labeled 2 over here? So the part which is labeled 2, what is this part? You can see approximately 4 parts over here exactly. And what is part number 2? So options over here are what? Is it a fixture? Is it an abutment? Is it an abutment screw? Or is it a crown? Now the correct answer to this is it is an abutment screw. The four different sections or components that you can see, let us try and label all of them. The first one over here, which is marked 4, it is your implant that goes within the bone, over which sits what is called as an abutment. We can see here that it is a straight abutment. This abutment is fixed with the help of an abutment screw. An abutment screw is used to fix the abutment. So the abutment would go fit into the implant, and then this particular abutment screw is used to tighten it up. Over this abutment in this region, the crown will come like this. So this is your crown that replaces the missing tooth and the crown portion of it. So pretty simple, but this time what I've done is I've changed the component that is generally asked. So now from here, I'm also simultaneously telling you what are the important topics also that can come for your exams. So from implants, what we have generally seen from components is that you will have an image based question, and generally surgical components would come. So you will have an image of ratchet, or you will have an image of some drill. Recently we had, I think, a question on pilot drill and its diameter, which is 2 millimeters. So this time I've changed it up and I've shown you the image of an abutment screw. Essentially, you are supposed to learn through all of the images of different implant components, since it encompasses basic implantology, which is expected of a student. So this is our first question over here. Now, second image based question, identify the type of smile arc in the image here. Now let me have a look at our chat. If you know the answer, student, can you please put in the correct answer in the chat box? I would get an idea whether you are able to solve these questions or not. So quite a few students have joined in for the session, and I'll request all of you, if you know the answers, you can just please put it into the chat box, and through that, I'll come to know whether you are able to solve these questions, or is it tough, is it easy for you, right? So the question here says, identify the type of smile arc in the image here. Now, what is a smile arc? Smile arc is this relationship of the edge of the incisors with this lower lip over here. And is it a flat arc? Is it a consonant smile arc? Is it a reverse smile arc? Or is it a non-consonant smile arc? And I can see quite almost all of you are able to answer it correctly. The correct answer is option number B, which is called as a consonant smile arc. So, like I said, smile arc is the relationship between the edges of the maxillary anterior teeth and the contour of the lower lip. Now, if this relationship is in a downward curve like this, as you can see over here, it is called as a consonant smile arc. If it is horizontal like this, it is called as a flat smile arc. And if it is reverse, which means that the centrals are placed upwards and the canines are downwards, then it is called as a non-consonant or an inverted smile arc, or also it is called as a reverse smile arc. So these are the different names. Now from here, what you can remember are these synonyms of it. It is called as a non-consonant also, inverted also, reverse also. It is also called as a flat or a straight smile arc. So you can just remember the synonyms so that if the same thing comes in your exam, you would be able to solve it up, right? So some image-based questions like these can come up in your exam. Now, from implantology again, which type of implant surface permits minimum bacterial adhesion? The question is, it should permit minimal bacterial adhesion. Is it plasma sprayed? Is it smooth surface? Is it a rough surface? Or is it a hydroxyapatite coated surface? Students, what do you feel? What could be the answer here? What could be the answer? Is it plasma sprayed? Is it smooth surface? Is it a rough surface? Or is it a hydroxyapatite coated surface? What do you feel is the answer? Right. So majority of you are right here. The correct answer is option number B, which is a smooth surface implant. Now, logic says that anything that is smooth surface will not allow adhesion of plaque or bacterial adhesion. Anything that has irregularities, either it is additive or subtractive in nature, which means anything that has an additive coating like hydroxyapatite, or anything that is subtractive, which has holes or porosities over it, it will allow adhesion of plaque. Does that mean that these surfaces are not good? No. They are helpful when you want to promote osseointegration. When you are in a situation where the bone is less dense, or it is maxillary bone, or it is a very porous bone, or you just want to enhance osseointegration in your patient, you could use different kind of surface characteristics, implants with different surface characteristics, so as to enhance osseointegration. So there are some advantages of these things and some disadvantages. Now, the point here that you need to remember is this thing. When we are in the hurry of the exam, it is a possibility that you will not read the end part of it very clearly and just look at the options, assume it is a PYQ, and quickly mark an answer. So there are two questions from this same thing. That is why we included here. It is a very pretty simple question, but there are two questions out of it. One question asks you about osseointegration. One question asks you about bacterial adhesion. If it is pertaining to osseointegration, the correct answer would be the implant surface that has some additive or subtractive surface treatment done over it. You will have to go through the options, and mostly it is a hydroxyapatite coated implant that has enhanced osseointegration. But when the question is pertaining to minimal bacterial adhesion, then the answer is smooth surface. So just keep that in mind, read the question correctly, and then move on to the next one. So, three questions down, and let us move on to the next question here. Now, first and foremost, can you all tell me what is this articulator? If you know the name of it, what is this articulator? What would this articulator be? It is correct that it is an Hanau articulator. Hanau is the company name. For example, for example, um, you go to a brand and then you say that you don't sub-specify. For example, if I say I'm wearing West Side, okay, but I don't specify what brand of West Side, something like that. It is Hanau, but you have to specify which Hanau articulator. So all of you are saying Hanau, 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 Hanau. Hanau is a company that has several articulators. Which Hanau articulator? Do you all know which Hanau articulator is this? Semi-adjustable is the type of it. Is the type or the classification. कौन सा Hanau? Hanau wide view, right? So good that we discussed this. This is Hanau wide VUE. Hanau wide view. Now why do we say Hanau wide view? This particular arm is wide. Posteriorly, it is wide and open like this. So it gives you unobstructed lingual access or lingual view. That is why it is called as Hanau wide view. It is an Arkan variety of articulator and it is semi-adjustable. So this is semi-adjustable and Arkan variety of articulator. So it is a semi-adjustable articulator Arkan variety. Now this here is the arrow it is pointing, and what is the question? What part of the body does the arrow in the articulator represent? Does it represent external auditory meatus, the temporomandibular joint, orbital component, or the cranial base? What do you think could be the answer here? Can you just quickly tell me in the comments? If you can just quickly tell me in the comments what could be the answer here. Quickly, if you can tell me what could be the answer here. What does it represent? I'll even show it to you. Simple questions, but very common mistakes. Now I can see quite familiar names in the chat. I can identify that they are my students. I've tackled them and met them before virtually, but fine. So the correct answer to this is in the definition of articulator. Go back to the videos on articulator or even any textbook, see the definition, and you will come to know that this assembly here, this particular assembly, that it is pointing an arrow at, it is pointing the arrow at an assembly. The assembly is representing temporomandibular joint. The assembly represents temporomandibular joint. So the correct answer is option number B, temporomandibular joint. Students, this is how silly mistakes happen in exam. This is how we feel that we have answered correctly but rank nahi aaya. Paper was very tough. Paper was actually easy. Precision is required while marking MCQs. Answer is there in front of you. Precision is required while marking MCQs. These different MCQs have put in the presentation for a reason so that you understand these small nuances of solving MCQs, right? So correct answer is option number B because that assembly of the condyle as well as the socket, it represents temporomandibular joint. It never represents external auditory meatus. That is just put in there so as to confuse you. Now, additionally, I can tell you one more thing. This, this is the orbital pointer. Fine. So that, sorry, that is the orbital pointer. This is the orbital pointer, which is the anterior reference point, but the assembly is TMJ. Fine. So is this part clear, everyone? If this is clear, can we quickly type all clear AC in the chat box and we can move ahead? All clear AC in the chat box and we can quickly move ahead to the next question. Excellent. Now, next is a fact-based question, something that requires memory, but something that is offbeat and something that goes to the big daddy of questions. Can you take a guess what PYT this is coming from? If you can take a guess on the PYT, I don't know, I cannot gift you anything, but I'll be very proud. So, can you guess the PYT from which this is coming? This particular, can you just guess the previous year topic here and simultaneously put the correct answer if you can? In the Vita shade guide, what is the shade of B? Red yellow, reddish brown, grey, reddish grey. Anybody? The previous year topic it comes from is shade selection. Shade selections, shade matching. I considered it the big daddy of all questions in prostho. From, I would say, decades, questions are coming. When I was a student, I solved MCQs of shade matching. Still today, questions of shade matching come. This is here to highlight one thing. Questions can be new, but the topic is the same only. Shade matching, everything around shade matching. If you read, you're done with that one, and it is a very high yielding topic. एक question तो आता ही है every time. So why not do something like this? That read that high yield topic and be done with it. You're sure you'll get one question out of it, right? So shade matching, very high yield topic. Very simple fact based question here. Answer is A, red, yellow. Most of you answered it correctly. Those who could not, just remember there are A, B, C, and D. Four different shades where A1 to A4 is reddish brown, B is reddish yellow, C is in the gray shades, and D is in the reddish gray shades. So you can just remember with this that first is reddish brown, second is reddish yellow, then gray, and then reddish gray. Now, let us go to question number 6. A 70-year-old patient has candidiasis under maxillary denture. What is the cause of it? Denture not cleaned properly, patient on long-term steroids, age of the patient, and malnutrition. A 70-year-old patient has candidiasis under the maxillary denture. What is the local cause for it? Denture not cleaned properly, patient on long-term steroids, age of the patient, and malnutrition. Dhanashri, can you please mention mnemonic you are asking for remembering A to D? I, for me, I just remember it as it is. I had memorized it years back and I remember it as it is. But I can try to make a mnemonic and maybe post in our group and you can have a look at it, right? So now here, all of you are correct as the answer. It is option number A, denture not cleaned properly. Now, this is a pretty easy question. The cause is generally that you're not keeping the denture clean, and that is why the patient has candidiasis. For example, you are a student who has not read anything about denture sequelae or anything about, I would say, candidiasis or any problems that occur with denture. Still, you will be able to solve this question very nicely. How? And correctly. How would you be able to do that? Is if you read the question completely and with patience, you will be able to find the answer in the question only. The question says 70-year-old patient has candidiasis under maxillary denture. What is the local cause of it? Local cause means the cause that is present at that particular site. Patient on long-term steroids, age of the patient, and malnutrition are systemic conditions. They are not local causes. There is only one local cause in the entire four options, which is option number A. This means that if you just simply know the definition, what means local and what means systemic, you can take 100% sure guess in such questions. This is how you solve MCQs in exam for new questions and cancel out options and take a calculated risk or a guess. Am I clear over here for all of you? Yes, so our very, very experienced students have already answered it in the chat. They know it over here. So the only local factor among all of this is A, that is unclean denture or poor hygiene with the denture. So this is how you would be able to solve all of these MCQs, right? So are you able to follow the session, students? Are you able to follow? Is the session going on fine for you? If there is any other query, please post it in the chat box. I'll be able to take it up. Now, condylar guidance is controlled, or I would say affected by all of the following except anterior guidance, muscle tone, nerve control, or bone fossa. What could be the correct answer here? The correct answer is anterior guidance. Correct answer here is anterior guidance. Let us have a look at what exactly condylar guidance is. So condylar guidance is the guidance that is generated by the condyles and the articular disc traversing through the contour of articular eminence. Basically, what condylar guidance is, for example, if you have your fossa like this, and this is your condyle, and the path that is taken up by the condyle, it is affected by this contour. It is affected by the shape of the glenoid fossa. It is affected by the ligaments. It is affected by the nerve control also, muscles also. But in no way anterior guidance is going to affect it. How anterior teeth are is going to be affected by condylar guidance, but the reverse is not correct. So anterior guidance is definitely affected by condylar guidance, but condylar guidance is never affected by anterior guidance. It is a fixed value for a patient. It cannot be changed by the dentist. We can only measure it with the help of protrusive records. So, pretty simple question, but it touches a very important concept. Now, again, a very important section from fixed partial denture, and this topic keeps coming in NEET more commonly than INICET. That is indications and contraindications of porcelain veneers. So, which of the following is a contraindication for porcelain veneer? 2 millimeters of diastema, high aesthetic demand, large extensive restoration, or a discolored tooth? Which of this is a contraindication? Question is asking a contraindication for porcelain veneers. Students, what is a contraindication here? Large extensive restoration. Exactly. All of you are correct. Option number C, large extensive restoration, is a contraindication for porcelain veneers. Now, let us have a look at a very important table, and you all can take a small screenshot of it also if you wish to. Indications of veneers are discolored tooth or teeth having diastema, teeth having some irregularities, or you don't like the shape of it, right? Contraindications are patient having high caries index, poor plaque control, and patient who are bruxers, or there is an end-on bite, or there are large existing restorations, or there is a very large endodontic opening that has been done to treat the tooth, something like that. Advantage of veneers are the superior aesthetics that it offers, plus there is minimal tooth preparation. But disadvantage, the very important disadvantage is it is very expensive in nature. So that is the disadvantage of veneers. Now, with veneers, always remember it is a bonded restoration. So in veneers, the traditional tooth preparation principles that you will cover a lot of surface area and prepare the tooth so as to gain retention and all does not apply, because once it bonds to the tooth structure, automatically the retention is because of the chemical bond that is forming over there. With veneers, we always have to check the bite of the patient such a way that it does not flick the veneer out of the mouth. It should not be hitting at the incisal edges. All of these things are kept in mind. For your exam point of view, remember this point. Veneer cannot be used when you have a large extensive restoration, right? So yes, Dhanashri is asking a question, why is it contraindicated? Dhanashri, if we go back to the basics of fixed partial denture, in that part, in the indications and contraindications of fixed partial denture only, it is written that we generally do not prefer fixed prosthesis in patients with high caries index because their hygiene maintenance might be poor. With the fixed prosthesis, again, it will go further down and the chances of loss of abutment always happens. So that is a general indication and contraindication for FPD only. In those patients, we prefer removable partial dentures because it is easier to take it out, clean it and maintain hygiene of the patients. Now, let us start with question number 9. Fine. So, another thing that we have seen very commonly that comes from implants are numerical questions. As seen in the image below, what is the minimum vertical distance that is required between the implant and the opposing occlusal surface? As seen in the image below, what is the minimum vertical distance that is required between the implant and the opposing occlusal surface? 8 millimeters, 6 millimeters, 9 millimeters, or 7 millimeters. What is the correct answer over here? The correct answer is option number A, which is 8 millimeters. For a fixed crown, this is for a single crown over here, right? So for a FPD, it is 8 millimeters. For an overdenture, for an implant supported overdenture, what is the value, students? What is the value for an implant supported overdenture? The correct answer for a fixed partial denture is 8 millimeters. For a overdenture, what is the value? So for an overdenture, the minimum value is 12 millimeters, but the range is 12 to 14 millimeters. Specifically, if we are making a bar supported overdenture, then we need to give at least 14 millimeters over there. So remember these values. Additionally, you also need to remember distance between two implants should be, and between a tooth and implant should be how much? Distance between two implants should be 3 millimeters and between a tooth and implant should be 1.5 millimeters. So additionally, remember it, that distance between two implants should be 3 millimeters. Distance between a tooth and implant should be minimum 1.5 millimeters. Remember, these values are important for exam point of view from implants. So without fail, never make any mistake in these kind of questions. See, this is an image from mesh where it has been established and given 8 millimeter is the height that is required for FP1. Now, let us go to our next question. This is something that I wanted to discuss. The function of indirect retainer is to prevent rotation of denture along which axis? Rotation along horizontal axis, rotation around vertical axis, rotation away from the tissue in posterior extension, or against an imaginary functional plane. Students, what could be the answer over here? What could be the probable answer here? Question number 10. The function of indirect retainer. Firstly, it functions in the sagittal plane. Bisector of the sagittal plane is this particular axis, which is what axis? This axis is a transverse axis. This axis, when it rotates like this, the rotation is away from the tissue in the distal extension cases. So the correct answer is option number C. The indirect retainer functions in the sagittal plane for distal extension, has a transverse axis like this. When you rotate the axis, it is rotation away from the tissue in posterior extensions. So answer is option number C. Now, additionally, I want to solve one more question and a doubt here. There is a PYQ that mentions that in unilateral distal extension case, what is the location of indirect retainer? And most of you want to select the answer, one that is across or away from the fulcrum line. There's another option which says mesial fossa of the first premolar. Now the correct answer there, which I ask you to follow, is the mesial fossa of the first premolar. Reason being, you are given a very specific situation, which is a unilateral distal extension case. So in a unilateral distal extension case, you will have a situation like this. So your fulcrum line is forming in this fashion, and the location is coming at the premolar only. And the word location is mentioned in the question. When it is mentioned in the question, what is the location? It is specifically asking you where do you want to place the indirect retainer, which is at the premolar. So that is a more appropriate answer. Several times it has been raised as queries, but to solve and shut all of those queries, that is the correct answer to it, not the option of opposite to fulcrum line or a very generic answer. It is asking you location. You need to mention the location over there. Now, dental materials, special tray or custom tray. Again, a question that has been asked several times as doubts in the group. So, a custom tray or special tray is fabricated with PMMA, should be made how many hours before the procedure? Is it just before, an hour before, 24 hours before, or 8 hours before? Now, generally, the confusion that I've seen here is many students say that is it 8 hours or is it 24 hours? So, be rest assured, the correct answer is option number B. It should be made before 24 hours so that even if there is an excess monomer, it leaches out. If there is any shrinkage, all of that is uniform and even so that your impression does not distort. Now, what happens if you make it just before your procedure? Right? Here is written over here, research indicates it has to be made 24 hours so that it is stable. Whatever shrinkage occurs already. What is the reason why 24 hours? So, a very practical way to tell you is, for example, if you made it just before your impression, पेशेंट वहां पे चेयर पे बैठा हुआ है, इधर भागा भागा ट्रे बना रहे हो, ठीक है, यू मेड द ट्रे, एवरीथिंग इज फाइन, ठंडे पानी में डाल दिया, ट्रिम कर लिया, impression is made. But whatever is the excess monomer, it will leach, it will evaporate, it will lead to polymerization shrinkage. That shrinkage is never uniform. So some parts of the impression will get distort, some parts of the impression won't get distort. This is happening after the impression has been made. And when whatever you construct over it, that is going to be inaccurate. But if the same has been done 24 hours before, whatever changes that are happening in the tray will happen before the impression has been made. So the impression does not get distorted. That is the straightforward reason why it should be made 24 hours before doing any impression procedure. Now, question number 12, as always, one of my favorite topics is the posterior part of mandible. One or the other question comes from here. Question is limiting structure in the distal-lingual sulcus of mandibular arch while recording impressions is what? Is it superior constrictor, tendon of temporalis, buccinator, or masseter? Students, what is the correct answer? Pretty easy question, very easy question. Something that my first year BDS student would also be able to answer. So you should not make a mistake over here. What is the correct answer to question number 12? Is it temporalis? Is it superior constrictor? Is it buccinator? Is it masseter? Also, a lot of questions come from this area. Again, a very, very, very important topic and a very frequently discussed topic. Matlab, every other session I've taught this. That is how common it is. Even on the free videos on YouTube or otherwise the discussions we have on application, almost every other session I've taught this. that diagram of retromolar pad area, its attachments poking out, what is the effect of masseter on buccinator, everything has been covered. Let us revise it, and yes, all of you are correct here. The correct answer is superior constrictor. So for one time, last time before the exam, let us draw that diagram once more. If this is your retromolar pad area, on the buccal side, you will have buccinator, and on the outer side of it you will have masseter. Then on the lingual side you have pterygomandibular raphe plus superior constrictor. Posteriorly you have tendon of temporalis. So these are the attachments. Also the effect of masseter on buccinator and the bulge it creates is leading to masseteric notch. That is what has been written here. Anteriorly, posterolaterally you will have superior constrictor, that is on the medial side only as such. And these are the attachments of the pad area as well as what are the structures lying in that region. Very important topic. Never make a mistake in this particular area. Now, what is the most common cause of failure of cast restorations? Is it ceramic failure, caries, periodontitis, or fracture? This is something that can confuse you, but remember your basics over here. What could be the correct answer, students? Question number 13. What is the correct answer here? Most common cause. It is asking, ऐसा नहीं है that बाकी reason से failure नहीं होता है, but what is the most common cause, right? This question also highlights one more thing. When you have a MCQ, all four options can also be the answers, but then you have to find out that one answer which is the most correct answer. So out of all of this, what happens more commonly? Caries happen. Most commonly we see caries only happening with restorations, and that is the correct answer. So caries is the most common cause of failure of cast restorations. Detection is very difficult, specifically secondary caries interproximally, very tough. And yes, I can see all of you are able to answer it, right? Let us move on to question number 14. Which of these is true about rest seat? Very good question. Which of this is true about rest seat? Should have a sharp line angle? No. Floor should be occlusal to the marginal ridge? No. Marginal ridge should be reduced? Yes. Rest seat and minor connector should be connected at 90 degrees or greater angle. Rest is connected with the minor connector. Rest seat is never connected. Plus, it should be connected at 90 degrees or lesser angle, not greater angle. So, correct answer is option number C. Marginal ridge should be reduced. Remember, marginal ridge is reduced by 1.5 millimeters. Then, this floor is reduced by 2.5 millimeters. So, if we draw a occlusal rest seat, somewhat like this, where the center is about 2.5 millimeters, marginal ridge is reduced by 1.5 millimeters. It has a spoon shape, and marginal ridge reduction always has to be done. Otherwise, the fracture of rest will occur, and the junction it forms with the minor connector, this angle has to be an acute angle. And all angles are always rounded. These are some important points that is pertaining to. Okay, now Dhanashri is asking why B is wrong. Dhanashri, the depth of the floor is 2.5, so it can never be occlusal to marginal ridge. It is going to be cervical to it. It is not occlusal to it. Occlusal means higher than marginal ridge, right? So that is why it is the wrong answer. So this is about rest seat. Now this is also one very important thing, that rest seat and questions pertaining to occlusal rest come very frequently in exam. So some features are there. What are there? It is a triangle shape. The base of the triangle is towards the marginal ridge. The apex is towards the central fossa. Center part is 2.5 millimeters deep. Marginal ridge is 1.5 millimeters deep. Buccolingually, mesiodistally, whatever the dimensions are, that you need to remember, 1/3, 1/2. That is what you need to remember. So these are just simple points. You can have a small chota copy with you, have those points, but something that you can remember at the back of your mind, right? Now, after you place an implant, ideal yearly bone loss should be. Bone loss happens inevitably with dentures, with implants, with anything. Apposition resorption is very common, affected by a lot of local and systemic factors. Is it 0 millimeters? No. Bone resorption happens. Is it zero point 0.2? Is it 1.5 to 2 millimeters? Or is it 3 to 4 millimeters? Students, what is the answer here? Correct answer, although I don't know if you might be knowing it or not, but correct answer is option number B, which is zero point 0.2, because it has asked you ideal yearly bone loss that comes from Albrecht's criteria. So, what are the criteria for implant success? You will have individual unattached implant is immobile. First and foremost, it is immobile whenever you are checking it. There is no radiographic evidence of peri-implant radiolucency. Matlab peri-implant, there has to be no bone loss or lucency. Vertical bone loss 0.2 millimeters annually after the first year of service of implant. Then absence of persistent or irreversible signs may, matlab, no such signs such as pain, infection, neuropathy, paresthesia, they should not be there, right? Success of 85% at the end of 5 year and 80% at the end of 10-year period. These are all different criteria, Albrecht's criteria. There are several criteria, but basic points are these, out of which the one point that is converted as a MCQ in exam is pertaining to vertical bone loss, which has to be lesser than 0.2 millimeters. Now, question number 16 is a continuation of what we have discussed earlier. Anterior condylar guidance can be altered by which of the following? Changing the lingual incline of upper anteriors, reshaping the incisal edges of upper posteriors, deepening the bite, or opening the bite. How can anterior condylar guidance be altered? Students, what do you think could be the answer here? Fine. So when you alter the lingual incline of upper anterior teeth, essentially change the palatal surface of the anteriors, you can change the anterior guidance that is present. So anterior guidance can be changed by this. Now, again, a very highly asked question in the group, torus. Torus कब निकालते हैं, torus कब नहीं निकालते, when can we relieve it? Lot of confusion is there around it. So let us try and solve it today. Surgical removal of palatal tori is rarely done. Specifically in maxilla, it is rarely done. Mandibular tori are removed very frequently. Surgical removal of palatal tori. Now, palatal tori is indicated when it is extending till soft palate, it is extending till PPS, cancerophobia, unfavorable undercut, or impinging the soft tissue. What do you say, students? When will you remove a palatal tori? A, B, C, D, E are your given options here. So, Harmandeep, she has mentioned the answer. Very quickly, she has mentioned the answer all, and she is absolutely correct. All is the correct answer over here. Option number D, all of the above is the correct answer. Remember, it is asking you indications of palatal tori removal. All of the options that are mentioned here are correct. D, all of the above is correct. Now, generally questions come pertaining to palatal tori about relief or surgical removal. Remember this one simple mantra. Torus extending till the junction of hard palate with soft palate, only and only relief. Okay? And beyond the junction, or it is mentioned, it is in PPS, all of this is mentioned, then surgery. Because a lot of confusion is there, when to give relief, when to do removal. Specifically, the question also does not mention the size of the torus here. So then you have to remember, torus extends till the junction of hard and soft palate. You have to give relief. If it is beyond the junction, you cannot place the posterior border, you cannot do a border seal. So irrespective of the size, even if it mentions a very small torus, if it is beyond the junction into the part where you place the border seal, you are supposed to do surgery and remove it. Is this clear? Is this part clear? Because this is one area from which a lot of students keep asking doubts, that they are not able to understand this. Is this clear, everyone? If it is clear, you can quickly write AC, all clear in the chat box. We can move ahead. Again, something that examiners are very fascinated with is Pontics. So in the end, I had to keep a question on Pontic. The Pontic design shown in the image below and its use. First and foremost, location already has been shown in the image. It is on an incisor. So, itna to from the question only you can figure out it is on incisor. What kind of Pontic it is? It is a modified ridge lap. So, correct answer is the one that encompasses B and C, which is this option. Option number B, that is 2 and 3. Now, I'm sure all of you would be able to solve this. Okay, everyone knows this. But then again, why the confusion over Pontics between ovate and modified ridge lap? So let us write it down. When anteriors and Pontics are in situation, aesthetics is of prime importance, and we have two options, modified ridge lap and we have ovate. Remember, you just need to remember something. Anything that mentions extraction, anything that mentions freshly extracted sites, anything that mentions these words, indication will always be ovate pontic. Anything that mentions surgical preparation of site, if all of these words are mentioned, anything that mentions a tooth is indicated for extraction, and immediately after extraction we are supposed to give, if it mentions fresh extraction site, if it mentions surgical preparation of site, answer is ovate pontic. But in all other situations, answer is modified ridge lap. This is your modified ridge lap. It covers on the labial aspect like this, but it has a gap here through which you can clean it up on the lingual aspect. All of the cases that don't have any surgical site preparation, you will not be able to deliver ovate pontic. So there the confusion only should not arise whether ovate is indicated or modified ridge lap. Modified ridge lap is going to be the indication there because you are not doing surgical site preparation. So that is the answer. For all posteriors, you are going to use conical, spheroidal, or sanitary, or these kinds of pontic. Saddle is never indicated. Saddle is out of question. It is not advisable, right? So some confusion was there between modified ridge lap and ovate. This was the confusion, and I hope that is clear. Now, any other doubt, students, that you want to ask, you can ask me those questions. Apart from that, there is a question pertaining to crown is to root ratio. Now, because there are some textbooks that mention ideal, optimal, and bare minimum, and questions are coming in question banks because of these words, there is a lot of confusion. Follow standard textbooks. Schillenberg mentions 1 is to 1.5 as ideal. There is no mention of the word optimal. 1 is to 1 is the minimum. So, as an alternative to ideal, you can even remember 2 is to 3. But there is nothing such as optimal over here. There's nothing like optimal. So, don't get confused in crown is to root ratio question. Ideally, in Schillenberg, it is written 1 is to 1.5 or 2 is to 3. You can consider that. Or bare minimum is 1 is to 1. That is it. Similarly, for taper, ideal is 6 degrees because of 3 degrees on each wall, and clinically possible what is there is 10 to 12 degrees. Clinically we can achieve this much. Because other textbooks use different terminologies, there is a lot of confusion, but don't fall into that trap. Okay. Now Gautam is asking, aesthetic also we have to go for ovate. Yes, ovate is going to be much more aesthetic than modified rich lab. Ria, the question that you are asking actually goes into endodontic management. So probably Dr. Aishwarya would be able to answer it better. But very briefly, if I tell you, fiber reinforced will be generally, or fiber post will generally be going in anteriors, where if the black hue of the cast metal is not appreciable over there. And secondly, I would say when you want to change the inclination or angulation of tooth, you can go for a cast post over there. But management of severely destructed endodontically treated teeth, just go into that segment with Dr. Aishwarya. He'll be able to answer your question better. Shivam, just yesterday we discussed the question that you are asking. So let me write it down again. Force between two unlike molecules is what? Shivam, can you tell me? Force between two unlike molecules. What is force between two unlike molecules? Force between two unlike molecules is called as, yes, right? Adhesion. Now, if the question is force of retention between saliva and denture, that is adhesion. Here the answer is adhesion. If the question is force of retention between saliva and denture due to a film of saliva, or it mentions due to saliva. Fine. This is interfacial surface tension. When it mentions it is because of saliva or a film of saliva, it is interfacial surface tension. Now, there's a question in veneers. Advantage is given as wear resistance. See, in bruxism, what happens is there's a lot of lateral forces that are generated. Because of those lateral forces, it has a tendency to dislodge the veneer. That is why in bruxers, we do not advise to use veneers. Okay. Can you repeat the upper unilateral distal extension? In unilateral distal extension situations, when specifically location has been asked in question, then you have to mention the option of premolar. The option that is mentioned premolar as the location, right? So with this, I think I've answered all of the questions that are present in the chat box, and even all 18-20 questions that were there as PYTs and previous year questions here. Remember, all of these are a way to make you understand first that previous year topics are very important. Second, questions come from the same type of topics. Third, how to address MCQs. Sometimes answer is there in front of you. You can take a calculated guess. Try and employ these techniques in your exam, and I'm sure your marks will improve, your GT ranks will improve, and you will come out with shining colors. Me, Dr. Ruchi, I'm wishing all of you the very best for your upcoming exam. Keep reading, do not waste time. Focus on what is there in front of you. May all of you reach your goals.